Okay, well, let's make a start. Well, good afternoon, everyone, and welcome to pediatric teaching for today. Last week we talked about anemia in children, and we talked about a variety of different things, including how to make a diagnosis of anemia by the history and the examination, and particularly looking at the different aspects of the full blood examination. Today we're going to just look at a number of different types of anemia, mostly the congenital forms of anemia, congenital or inherited forms of anemia, and several types of anemia that lead to haemolysis. Now, last week we mostly talked about iron deficiency and nutritional anemia, but this week we'll talk about some congenital forms of anemia. But just to recap a few things, we said that I think we don't make the most of looking at the full blood count all the time, the full blood examination or the full blood count. And we can detect a lot more about a child's cause of anemia by looking at these basic parameters. So we should obviously look at the haemoglobin, which is the amount of haemoglobin in grams per deciliter of blood. You all know that. And then there's the MCV, which is the red cell volume, the mean cell volume, the average volume of the red cells. And then there's the RBC, which is actually it's the number of red blood cells within a ml of blood. And we talked last week about the RDW, which is the red cell distribution width, which indicates the variation in the size of the red cells. So the MCV tells us about the average size of the red cells, and the RDW tells you about the variation in size. So if there's a lot of small cells and a lot of large cells, then a wide variety of different sizes of cells or shapes of cells, then the RDW will be high. And that can be a good clue to different types of anemia, like we talked about last week about iron deficiency anemia. But also this week, the RDW is often high when you've got a form of hemolytic anemia, different sorts of hemolytic anemia. We also talked about this. So they're the main parameters, the main four parameters of the red cells that you look at when you're looking at a full blood count. But also, if your laboratory can do it, then you can ask the lab scientist to count the number of reticulocytes. Remember, we said that the reticulocytes are the number of immature forms of the red cells. And it's if you see a high reticulocyte count or a high percentage of reticulocytes, then that means there's presence of new red blood cells. So firstly, it tells you that the bone is actually working because it's making new red blood cells, and it can give you an indication as to what type of anemia it is. So there's various types of anemia, like with hemolysis, blood loss, that gives you a high reticulocyte count. So that can be a useful clue. And if the reticulocyte count's low or zero, then it tells you it's a clue to the fact that the bone marrow is not working. And then lastly, when you're looking at the full blood count, you're looking for other clues as to bone marrow failure. So sometimes when the red cells have failed, then also the white cells have failed or the platelets will have failed. So you're looking at the number of whether there's neutropenia or leukopenia or thrombocytopenia. So when you're looking at a full blood count for a child with anemia, then look at those things. Last week we talked about how there is a system that you can go through to identify different causes of anemia, and it sort of starts, as I said before, with the hemoglobin and then with the MCV. I won't go through all this again today because we talked about it last time, but using this sort of framework, you can actually work out the underlying cause of most causes of anemia just by, again, taking a good history, doing a thorough examination, and then looking at the full blood count in detail. And, you know, it's sometimes you, of course, need to do bone marrow aspirates, or you need to measure folate levels or B12 levels or other tests like a Coombs test. But most of that, you can get much closer to the cause of anemia by simply looking at all these parameters. So I wanted to start off today by, thank you. I wanted to start off today by just going through a case. And I think it's a very interesting case, and it illustrates some important things that we sometimes face. This was a 14-year-old boy who presented with fever and pallor and weakness. Now, he'd been that way for several days, and he'd presented to a health centre before, a few days before, and he was diagnosed with malaria. Now, he had a mixed malarial infection, so on the rapid diagnostic test, it was clear that he had both P. falciparum and Plasmodium vivax, and he was diagnosed 4 days before and then treated with artemether, lumefantrine, and primaquine. But he'd become weaker in the last 2 days, and he'd developed a fever. At that stage, his heart rate was 105, his respiratory rate was 28, and his blood pressure was 107/71. He didn't have any respiratory distress. That's a picture of him there. You can see sitting on the bed, no respiratory distress, but he was cyanosed, and he did have an oxygen saturation of 69% in room air. And he looked very pale, so very pale, a bit cyanosed, hypoxemia, not much in the way of respiratory distress, and vital signs that were not a lot out of the normal range. But that's the story. So I wonder if anyone could suggest what could be wrong with him. Yes?
Maybe hemolytic?
He could have hemolytic anemia. Yeah, what sort of hemolytic anemia? There's several people giving answers. I'm not sure what you're saying, but we'll keep going. So as I said, he presented with 2 days of he had malaria for 4 days or more, and he presented with weakness and pallor. And the question is, what could cause severe oxygen desaturation but minimal respiratory distress? I'm not sure whether you've seen this, but he also had tea-coloured urine. So that would go along with what Phyllis said, which was haemolysis, wouldn't it? It would go along having tea-coloured urine, and you can see his oxygen saturation of 69% there. His hemoglobin was 5.6 grams per deciliter. Remember, we measure hemoglobin either in grams per litre or grams per deciliter, so 5.6 grams per deciliter. His MCV was 75, and if you remember roughly what the MCV is, that's within the normal range. His red cell distribution width was 19.3, which again, if you have looked at enough full blood counts, you'll know that that's a bit high. The normal is up to about 14 or 15, but 19.3 is a bit high. So that again tells you that there's variation in size and shape of the red blood cells. And his reticulocyte count is 4%. So again, if you've looked at a number of red full blood counts, you might realize that a reticulocyte count of 4% is a bit high, isn't it? And so that would be in keeping again with what we said. A hemolytic anemia is likely to be normocytic, normochromic, isn't it? Likely to be normocytic. It's not like it's iron deficient, so hypochromic, and it's not B12 or folate deficient, so it's not macrocytic, but an MCV within the normal range is consistent with one of the normocytic anemias or hemolysis. And his red cell distribution width, remember we said that you can see a high RDW when you've got hemolysis because you've got different sizes and shapes of red cells, and the reticulocyte of 4% suggests that his bone marrow is working quite hard to produce red blood cells potentially because the other red blood cells are breaking down. This is his blood, and his blood looked very brown, if you like. It was a brownish color compared with normal venous blood, which is not normally quite so brown. So he had evidence of hemolysis, and he had the possibilities are that he had G6PD deficiency, most likely, or maybe malaria with hemolysis, or maybe a condition called hemolytic uremic syndrome, where there is an infection that leads to both impaired kidney function and hemolysis. It would present in a similar way, except often the children are looking much sicker than this. The question is, why would he have such severe oxygen desaturation? With malaria and hemolysis, you don't usually get such severe oxygen desaturation, and with hemolytic uremic syndrome, you don't. But with G6PD, you do get severe oxygen desaturation. And does anyone know the reason for that? People are trying to give an answer, but it's really hard to hear. I'm sorry, but we'll keep going. This was his blood film. And again, we looked at a blood film of a child with iron deficiency anemia last week, and those red cells were relatively circular and smooth. But you can see the red cells in this blood film are not circular. They're quite irregular shapes, aren't they? An irregular shaped blood, the outline of the red cells are irregular shape. They've got lots of sort of indentations and knobbles on them, and they're often called bite cells. And you can see actually in here just what's called a Heinz body. You know, you don't need to be an expert in looking at blood films. The hematology people might tell you about what's in the blood film, but it's useful to know a Heinz body is broken down hemoglobin, where you've got evidence where the hemoglobin is not functioning well, so it aggregates like and becomes quite prominent in the red blood cells. So these are Heinz bodies and bite cells, and you can see the difference is in size and shape of red cells, which is called poikilocytosis, a large variation in the size and shape of them. Again, consistent with severe hemolysis. And as I said, the Heinz bodies represent damaged hemoglobin that aggregates within the red blood cell. So again, we've got a child who's got the clinical features that are consistent with hemolysis. And the question is, why has he got oxygen desaturation? Has he also got some respiratory infection, or is it something else as well? Well, he's likely to have G6PD deficiency, and that's a X-linked recessive disorder. It's relatively common in certain parts of the world, and especially in PNG and certain parts of Asia. And it's an X-linked recessive disorder, which means it most commonly occurs in boys. It can occur in girls as well, but it's only if they are homozygous for the abnormality. Whereas boys can be hemizygous. They can have one X chromosome that's abnormal, and then they have G6PD deficiency. The reason why it's common in Papua New Guinea and some other countries, anywhere there's a lot of malaria, because the parasite grows quite slow in G6PD deficient red cells. That's the surprising thing. It gives some protection against malaria, but paradoxically, when we give some drugs to treat malaria, then a child might manifest G6PD. So it's a perfect storm in a way. Most commonly, the boys are affected. As I said, they're hemizygous. Girls can also have hemolysis if sometimes girls can have one X chromosome that's inactivated, and so the other X chromosome that's got the deletion on it, then the other X chromosome can then be dominant, if you like, a bit like a boy. And sometimes they're homozygous if they've got two faulty genes. If you've got a population where G6PD is very common, then you can have girls that are affected as well. And they often have very severe hemolysis almost spontaneously whenever they get a fever or a respiratory infection or something like that. And of course, if they get primaquine or they get some other sulfonamide or some other affected drug. I won't explain all of this, but this is sort of what G6PD does. G6PD is an enzyme that protects the red cells against oxidative damage, right? And when there's lots of things that I wonder if you could mute your screens. I might just get people to mute their microphones if you can, please. So G6PD is an enzyme that protects the red blood cells against oxidative damage. And when you get any an infection, a fever, certain drugs can lead to oxidation or the production. Oxidation is really the production of hydrogen peroxide from water. And G6PD protects the red cells against the damaging effects of hydrogen peroxide on the hemoglobin. And the effect of that is that normally hemoglobin exists mostly in the ferrous form, that's iron 2+. You know, there's iron within the hemoglobin, but if there's oxidation of the hemoglobin, then it turns it into the ferric form, iron 3+, and that's called methemoglobin. Whereas ferrous hemoglobin, iron 2+, that can carry oxygen. Ferric hemoglobin, that is methemoglobin, that can't carry oxygen. So if you've got an oxidative stress on the body, any sort of oxidative stress that leads to oxidation of hemoglobin, then you'll get more production of methemoglobin. And the reason why the oxygen saturation is low is because the oxygen saturation is the percentage of hemoglobin that is carrying oxygen. And we all know if a child's hypoxic, if they've got a low oxygen delivery because of pneumonia, then they'll have a low percentage of their hemoglobin that is carrying oxygen. But if a proportion of your hemoglobin can't carry oxygen because it's in the ferric form, because it's methemoglobin, then your oxygen saturation will be low because you'll have a mixture of normal hemoglobin and methemoglobin. And even if your methemoglobin is like 30%, then your oxygen saturation at its best can only be 70%, because oxygen can only be carried by the normal hemoglobin, not by the methemoglobin or the ferric hemoglobin. So that's what G6PD protects us against, is oxidative damage to hemoglobin. I wonder if everyone could mute their devices, please. Yeah, that's what G6PD protects us against, and that's the reason why when you see a child with G6PD hemolysis, they'll have oxygen desaturation. Now, the pathway to all of that is complicated. This is the G6PD enzyme. I won't go through that, but the main message is when you've got any sort of oxidative stress, like where a child has got G6PD deficiency, if they eat broad beans or they get exposed to naphthalene, which is in mothballs, or they get given primaquine or non-steroidal anti-inflammatory drugs, or sulfonamides like cotrimoxazole, napsone, or they have a fever or an upper respiratory tract infection, or they get really dehydrated, depending on their level of G6PD deficiency, they can get severe hemolysis. And all it does is it makes more methemoglobin, which is unable to carry oxygen. And that's why their oxygen saturation is low, as well as they're having a severe hemolytic anemia. I won't go through this in too much detail. This is another patient who had G6PD deficiency, and it tells you something about the rate at which the hemoglobin falls. And as I say, I won't go through this in too much detail, but this child was exposed to hydroxychloroquine around this time, and the hemoglobin fell 2 to 4 days later. And at the same time, the bilirubin rises because of hemolysis, and the methemoglobin level rises. So there's what typically happens is 2 to 4 days after exposure to some sort of inciting event that leads to hemolysis, then the hemolysis occurs, the red cell count falls, the hemoglobin drops. A day or so later, the bilirubin level rises, and while the hemoglobin is dropping, then the methemoglobin level also rises. Sometimes you can measure the methemoglobin in a blood gas. That's probably the only way of measuring it, apart from inferring it by the fact that the child had got oxygen desaturation. So again, just to explain this in one more time, G6PD is an enzyme that protects the red cells from oxidative stress. And oxidative stress transforms ferrous hemoglobin, which carries oxygen, that's our normal hemoglobin, into ferric hemoglobin, that is Fe3+ or methemoglobin. And methemoglobin can't carry oxygen, but normally we've got less than 1% methemoglobin in the blood. But under conditions of oxidative stress, sometimes the methemoglobin level can go up to 3 or 40%. So if it's 40% of the hemoglobin is methemoglobin, it can't carry oxygen. So the patient therefore is cyanosed and desaturated. They've got an oxygen saturation of only 60%, even if their lungs are normal. Their lungs can be normal, but they can have a severe oxygen desaturation, not because of the anemia, but because they've got a proportion of their red cells are methemoglobin, right? Okay. I mentioned before that G6PD is a genetic disorder. It's X-linked recessive. There are about 140 mutations, so lots of different forms of G6PD, and there's several hundred biochemical variants. So they differ in terms of severity and susceptibility to stressors and different agents. And the diagnosis is largely clinical. You can base it on a clinical diagnosis, but you can also do an enzymatic diagnosis, a laboratory test for G6PD, and that analyzes the amount of NADPH. You remember in that diagram before I showed there was NADPH was one of the coenzymes and the cofactors involved in the protection of red cells from oxidative stress. That's what is mostly measured in the laboratory test for G6PD. Don't worry about the laboratory basis for this, but you can either do it clinically or enzymatically. And it's usually based on a clinical picture of a haemolysis that occurs 2 to 4 days after drug exposure. The peak is around about 8 to 12 days. It always goes away. So after, as long as the exposure has ceased, then 8 to 12 days later, the haemolysis will resolve. It can also, G6PD, if it's severe, can present with neonatal jaundice. That's one of the earliest, more severe forms of G6PD. And sometimes it can present with chronic hemolytic anemia, where children have chronic pallor and jaundice and splenomegaly, and they require multiple transfusions, and they may have gallstones because they've got chronic hemolysis. So there's 3 different clinical manifestations. The one that we, I guess, see quite commonly is hemolysis occurring after drug exposure. The treatment is mostly supportive. You should try to maintain the urine output. When you've got hemolysis, there's a possibility that the kidneys will become impaired. You should transfuse a patient if their hemoglobin is less than 6 grams per deciliter, and you need to avoid, of course, oxidative stress, drugs and fever, dehydration and acidosis. And the sorts of drugs that are most affected, as I mentioned before, G6PD was described most commonly with eating broad beans or fava beans, it was originally in Africa was called favism. That's where the term originated from, in India and in Africa, favism, because of the most common reason in certain countries is because of the ingestion of fava beans. It also can occur because of the ingestion if small children eat mothballs. If in the past that was relatively common to put naphthalene in the cupboard or the closet to try to reduce the risk of insects and other moths and other insects eating clothes, and that caused G6PD. And primaquine is probably the most common these days as a trigger for G6PD. Non-steroidal anti-inflammatory drugs like ibuprofen and diclofenac and paracetamol, and then sulfonamides, including cotrimoxazole and dapsone in the treatment of epilepsy, and nitrofurantoin is a trigger as well. That's a drug, an antibiotic that's sometimes used to treat urinary tract infections. And then if any children get a fever or an upper respiratory tract infection, or they get dehydration, that can trigger a G6PD oxidative crisis. I wanted to move on now to a different form of congenital anemia and move to thalassemia. And this is important for those who are doing the part 1, and also for those who are looking after children with thalassemia, to have some understanding of the biological basis of thalassemia. And to go back to the first principles, hemoglobin is made up of 4 peptide chains, and each of them is bound to a heme group. So there's 4 protein chains, and there's 3 options for what the heme group is. It's either alpha, beta, or gamma. And most of us know about hemoglobin A, that's adult hemoglobin, and that's got 2 alpha and 2 beta chains. Right? And then hemoglobin F is fetal hemoglobin, and that's got 2 alpha and 2 gamma chains. Right? This is important for thalassemia because I'll explain why in a minute, because depending on whether you've got alpha thalassemia or beta thalassemia, you might rely more heavily on fetal hemoglobin. For example, if you've got beta thalassemia, that you'll rely quite heavily on fetal hemoglobin. And there are ways in which that amount of fetal hemoglobin can now be manipulated to provide a higher level of hemoglobin. There are differences in the phenotype depending on whether it's alpha or beta, and depending on whether the number, what number and type of the peptide chain is abnormal. And this is what's important, that if you've only got one abnormal gene, then mostly people are asymptomatic. In fact, they're protected, just like G6PD, they're protected against malaria. All right, I'll go through this in a bit more detail. But if you've got more than 3 or 4 genes are abnormal, then you'll have severe thalassemia. So as I said, there's 2 types of thalassemia, alpha and beta. You all know that. And for the alpha globin genes, there are actually 4 of those. And you can have either 1, 2, 3, or 4 alpha globin genes, the peptide genes that are abnormal. If you've got one, then there's no symptoms at all, and all you are is protected from malaria. You don't have haemolysis, you don't have anemia, you're just simply protected from malaria. And that's extremely common in certain populations in PNG and many other populations where malaria is common, especially on the north coast. If you've got 2 alpha globin genes abnormal, then you've got a child will have thalassemia minor. Now, that's a very mild disease, and often the hemoglobin tends to run about 7 or 8, and generally there's no symptoms. Again, there is some protection against malaria, but there's no other symptoms usually apart from a mild hemoglobin, a mild anemia. But if you've got 3 abnormal hemoglobin, genes for the alpha globin gene, then you've got what's called hemoglobin H disease. And instead of having 2 alpha and 2 beta, then what you end up with is just 4 beta genes in most of your hemoglobin. And those children will have hemolytic anemia and jaundice from the time of birth. And then the worst form, or the most extreme form, is when there's 4 gene defects or all the 4 peptide chains have a gene defect, and then you'll have hydrops. That is, the baby can't make any hemoglobin, because remember that for the alpha globin gene, alpha globin chain is essential for both fetal hemoglobin and for adult hemoglobin. So if you've got 4 genes that are deficient, then you can't make either fetal hemoglobin, nor can a child or an infant make adult hemoglobin. And that's called hemoglobin Barts, which is babies are usually stillborn or die soon after birth, usually stillborn with severe hydrops. So there's a wide variety of severity of alpha thalassemia, from completely asymptomatic to fatal at the time of birth. Beta thalassemia is a bit more common in terms of its children who have what we consider to be thalassemia. They have chronic need for transfusions. There's 2 beta globin genes, or two beta globin genes, and you can either have one of 3 things. You can have only one genetic abnormality, and that gives you, again, thalassemia minor. And those children run with a hemoglobin that's about sort of 7, usually most of the time. They're normal and they're generally fairly healthy, and they're heterozygous. So they, of course, could give birth to a child when they to a child who has severe beta thalassemia, or they could remain just heterozygote and relatively asymptomatic, sometimes with a hemoglobin that's a bit lower than normal, so 7 or 8. If you've got 2 of the beta globin genes that are abnormal, not absent, but abnormal, then you have what's called thalassemia intermedia, which is just some sort of intermediate form of thalassemia. And you'll see children with that have a degree of thalassemia. They need their blood transfusions on a regular basis, but not as severe as if you've got two of the beta globin genes that are completely absent. Then you have thalassemia major, or what's called Cooley's anemia, where they're again the typical form of severe thalassemia we sometimes see in children. So the point is, there's a very wide variety of thalassemia, from mild to severe, and there's even more variety within that, because there's hundreds of genetic abnormalities that can cause the gene defects, and each one of them is a bit different too. Alpha thalassemia is quite common in Papua New Guinea, as I mentioned, where malaria is hyperendemic, especially when there's on the north coast, where malaria has been hyperendemic for many generations. Then alpha thalassemia is very common, and usually it manifests as thalassemia minor, but of course it sometimes manifests as thalassemia major, like this boy here. Its distribution is a bit like G6PD deficiency, again, where malaria is common. And I won't go into this, but in the highlands of Papua New Guinea, there's been studies done that look for severe alpha thalassemia, and it's extremely rare in the highlands, and that makes sense because there's much less malaria there. Remember, I said that beta thalassemia can be either thalassemia minor with 1 beta globin gene absent, or thalassemia intermedia, where there's an alteration to the beta globin genes, but they're not absent. They're there, but they're not absent. And then thalassemia major, where both beta globin genes are absent. And as I said, there's 200 or more different genetic mutations in thalassemia, and they're different in Papua New Guinea than what they are in Italy, and they're different in Africa, and different in different parts of the world, but they all lead to abnormalities of the beta globin gene. Sometimes when you see a child with thalassemia major, then they generally are progressively more pale from about 3 months of age, when they lose their fetal hemoglobin and the adult hemoglobin has to take over. Remember, fetal hemoglobin is 2 alpha and 2 gamma, so that's not affected by beta thalassemia. But when the fetal hemoglobin is dropping, then you start to see symptoms from thalassemia. They look progressively pale. They have feeding problems and irritability, mostly because they're just more anemic. They develop massive hepatosplenomegaly because of hemolysis, and also because they're in the liver and the spleen and in the bones. Of course, there's extramedullary hemopoiesis. The bone marrow is not, the normal bone marrow in the long bones is not sufficient to make all the blood that you need to make. So there's more hematopoiesis going on in the liver and spleen, and also in the other bones. I'll show you some x-rays in a minute. They have poor growth and poor muscular development because basically all their energy is being used up for the production of red cells. They're prone to pathological fractures, not surprisingly, because their bone marrow is expanded, and the cortex of their bone is rather thin. They have what you recognize as frontal bossing and maxillary prominence. These are features in the child I showed you before: frontal bossing and prominence of the maxilla. That's what they typically look like. And they have, even from early on, they have an increase in their gastrointestinal iron absorption. Now, we get used to thinking that children with thalassemia only get iron overload when we transfuse them, but they also, for some reason, increase their gastrointestinal iron absorption, so they can get hemosiderosis of the liver and the heart quite early on. Of course, much more when we transfuse them, but even from relatively early on. The treatment for thalassemia has improved, I'd say, over the last 20 years. It's obviously there's many different ways you can treat it now, but even the basics of knowing that it's important to keep these patients transfused up to a hemoglobin above around about 10. When you transfuse them, you should aim to get them to 10 or 11 or 12 so that they have a longer period of time when they're not severely anemic. Remember that each unit of blood you give contains about 200 milligrams of iron. So you're giving a lot of iron to these patients every time you give them a unit of blood. And so these patients, once they start having regular transfusions, they do need iron chelation therapy. Now, this has been hard to come by in Papua New Guinea and many other countries, but it's increasingly available, and it can be obtained now. There's the main thing you need to know about this is there's two types of iron chelating therapy. There's that which has been available for a long time, like many decades, called desferrioxamine or deferoxamine. But the children need to take it as a continuous subcutaneous infusion. That's really hard to take. 18 hours of a subcutaneous injection. They need to take it at home, of course, as well, virtually all the time. And that became extremely difficult and for children to take. But now there are some oral iron chelating agents. And what that means is that chelation means that if you, it extracts iron. So instead of the iron from the gastrointestinal tract being absorbed into the bloodstream and causing more hemosiderosis, like hemochromatosis, it absorbs iron back from the bloodstream into the gastrointestinal tract, and then it's excreted out. So iron chelating agents are really important for these children. And if they get early onto an iron chelating agent and they get blood transfusions that keep their hemoglobin above 9.5 grams per deciliter, that's the standard of care. And those children can do reasonably well. Of course, it's very hard to get these iron chelating agents at the moment, but that should be the standard of care. You should start the iron chelating agents as early as possible, even if you make a diagnosis and the child doesn't quite need blood transfusions on a monthly basis. It's good to still start so that they don't get increased gastrointestinal iron absorption. So in most places where there are thalassemia clinics, they will start iron chelating agents earlier, like as soon as the diagnosis is made, essentially. The problem, of course, is the complications from thalassemia, and the complications include that children have obviously chronic anemia, they have poor growth, but they also have iron deposition in their heart, so they can have a iron-related cardiomyopathy. The iron gets deposited in their heart, in the heart muscle, and in the liver, and they can get cirrhosis. The picture of the boy I showed you had both a severe iron deposition in his heart and in his liver, and like many children with thalassemia, they pass away despite regular iron transfusion from their cirrhosis of the liver or their cardiomyopathy, usually in the teenage years. The iron also affects other organs, the endocrine organs, and particularly, and that's why these children often have growth failure and have other endocrinopathies. They have diabetes sometimes, or very delayed puberty. And then there's the transmission of viral infections through blood, which of course are much, much less likely now that blood is screened for hepatitis B and C and HIV. It was a big problem in many countries in the 1980s before blood was screened for HIV, but it's not now. The other treatment for children with thalassemia is really supportive. They're trying to provide them with adequate nutrition for growth, and I think psychological support for them and social support for their families is very important. Sometimes it's splenectomy is tried if they've got a really massive spleen, because that can reduce the amount of haemolysis they have. And also there's a drug now called hydroxyurea, which is good if you've got beta-thalassemia. If you've got beta-thalassemia, then again, as I said before, that you're relying a lot on your fetal hemoglobin, and because fetal hemoglobin is 2 alpha and 2 gamma, and you're relying a lot on fetal hemoglobin. So there's a drug called hydroxyurea, which increases the concentration of, or increases the production of fetal hemoglobin. And instead of losing it completely after about 6 months of life, then you can keep making it. There, in some countries, in parts of Europe where thalassemia is very common, they're doing bone marrow transplants, and there's other gene therapy for thalassemia. But the basic things are to transfuse and chelate iron if you can, and then other supportive care for the child and their family. Now, so we've talked today about G6PD deficiency and the biological basis for that. We've talked about thalassemia and the genetic basis of that, and why it's sort of more common in some countries, particularly in Papua New Guinea and in the north coast where there's malaria. But it's important to know something about the genetics of thalassemia and something about the clinical manifestations of G6PD, so we can recognize that. I wanted to talk just briefly about indications or blood transfusions. We talked briefly about this last week, but I wanted to go through this in a bit more detail, and then we'll finish off. But first of all, as I said last week, when we decide to give a blood transfusion, it shouldn't be based on just a number. It shouldn't be based on the amount of hemoglobin. I've seen lots of children with a hemoglobin of 4 grams per deciliter who don't need transfusion because their problem is just nutritional. It's related to iron deficiency. And if you can correct their nutritional problem and give them iron, then they'll make more red cells by themselves. And as long as you can follow these patients up, then that's okay. So it's not about the number. It's really about, you have to consider the whole clinical picture to decide whether to transfuse a child. Usually we transfuse children who are less than 7 grams per deciliter, 1, because follow-up might be difficult, 2, because they might have a progressive condition, 3, because it might not be, their anemia might not be correctable with a hematinic agent by just giving them iron or B12 or folate. So there's many reasons why our practice is to transfuse children when they've got a hemoglobin less than 7, but you've got to think about why you're transfusing a patient, not just decide that because their hemoglobin's 5, they should be transfused. If you've got a child who can start on iron, can stop drinking lots of cow's milk, can change their diet, and their nutrition is otherwise okay, then there's no reason why you need to transfuse that child and expose the child to a unit of blood. But if they're, I guess the most common scenario we see children with severe anemia is when they are otherwise unwell, when they've got a respiratory infection and they're needing oxygen, or they have some degree of respiratory distress, or they may have other comorbidities, co-infections, and so those children will generally transfuse when the hemoglobin's less than 7. So the indications are really how sick the child is, not whether or not what the hemoglobin is. If an anemia is worse than if it's untreated, like a child's got leukemia and they've got anemia, you know that that's going to get worse, so that you have a lower threshold for transfusing that child. It's only if it's correctable with simple measures, by like giving iron, that you would decide, I don't need to transfuse this child. I was going to talk about how you calculate a blood transfusion, and you can calculate the amount of a packed red blood cell transfusion. We're primarily talking about packed red cell transfusions, not whole blood transfusions, but you can calculate the amount of red blood cells to give by this formula, and it's what's called the delta hemoglobin, which is measured in grams per deciliter, times the weight of the child, times a factor of 4. Some people say a factor of 3, but usually 4 is a better transfusion, but gets them up to a better level. And I'll explain what this means. So the delta hemoglobin is the hemoglobin you're aiming for minus the hemoglobin the child currently is. Remember, it's in grams per deciliter, not grams per litre. And you multiply that by the weight and by a factor of 4. So for example, an 18-month-old child, a girl who weighs 12 kilos with a hemoglobin of 5 grams per deciliter, who has pneumonia and heart failure she's requiring 3 litres of oxygen via nasal prongs, and her oxygen saturation is still only 90%. Most of us would transfuse that patient. Haemoglobin 5, saturation 90%, on oxygen, with pneumonia and heart failure. Most of us would transfuse that patient. So how you work it out, the volume to transfuse, the hemoglobin you're aiming for, let's say you're aiming for a hemoglobin of 10, and currently that child's hemoglobin is 5. So that's 10 minus 5 times the weight, which is 12, times a factor of 4. So that's 5 times 12 is 60, times 4 is 240 mils of red blood cells. Now that's a unit of blood. So this child, this 18-month-old child, could have a unit of blood to get their hemoglobin up to 10. That would reliably get their hemoglobin up to 10. So you need to work out first of all, am I going to transfuse this child? Is there an indication to transfuse? What volume will I transfuse? And then what rate will I transfuse? And so the maximum rate you can transfuse is over 4 hours. And the reason for that is if you hang blood for more than 4 hours, then there's an increasing risk of bacterial contamination of that blood. Because it's been blood at room temperature, you may get contamination of the blood if it's hung for more than 4 hours. So therefore, with this child, you could give, the blood could be given at 60 mils an hour for 4 hours. That would be the way you'd probably transfuse this child. You can give it quicker, of course, too. If a child's got hemorrhage, for example, then of course you're going to give it quicker if they've got hemorrhagic anemia. But if a child's got pneumonia and heart failure, you'd probably give it a bit slower, over 3 to 4 hours. And you'd give it with some frusemide to make sure that the child didn't get heart failure. And so I typically give like 0.5 to 1 milligrams per kilogram before the transfusion, just when the transfusion is starting, so that they start passing urine and effectively making space for the transfusion. And sometimes I would assess the child as the transfusion is going in. And if at the end the child had not passed enough urine to start with, or if their heart failure or their oxygen saturation was no better, or if it was any worse, then you'd give them another 0.5 to 1 milligram per kilogram of frusemide. So you need to be flexible, but you need to monitor the child throughout the transfusion to decide whether you're going to give another dose of frusemide at the end of it. I wanted to briefly touch on a concept that I'm not sure whether you're familiar with, but it's called a massive blood transfusion. And this really only occurs in where you've got trauma-related injuries, where a child is bleeding a lot, or surgical bleeding, where there's a large bleeding. This is different to the child I talked about before, who has a respiratory infection and has a hemoglobin of 5. That's a different situation. This is where you've got a child's got hemorrhagic shock, and where they need a massive transfusion of blood. Now, so for example, that 12-kilogram 18-month-old child, if she needed 40 mils of packed red blood cells per kilogram, that would be 480 mils, but twice as what we were giving her before, twice the amount. If she had a form of severe hemorrhagic hypovolemia and anemia, that's 2 units of blood. That would be a massive transfusion in this child, and again 40 mils per kilo of blood. The reason I'm talking about this is because if you have to give that much blood in an emergency, then what you'll run into is what's called a dilutional coagulopathy if you're giving packed red blood cells, because you're replacing a lot of the patient's own blood because they're bleeding so much. And what you're not replacing when you're giving packed red blood cells is you're not replacing the clotting factors that are in plasma, and you're not replacing the platelets. And so if you have to give 40 mils per kilo of blood or more than that, then you need to also give some fresh frozen plasma and some platelets as well. So usually after 40 mils per kilo of blood, then you'd give 1 unit of FFP and 1 unit of platelets for every unit of blood you gave after that. That's very important, because otherwise the patient will keep bleeding because they've got a dilutional coagulopathy and they'll just keep bleeding. if you've got a child who's got that degree of hemorrhage and needing a massive transfusion, then you should also give tranexamic acid for trauma or surgical bleeding, because that can help stop bleeding. Okay, so I won't talk too much more about a massive transfusion. That's not what how we usually transfuse patients, but just to know that if you're giving more than 40 ml of blood, you should consider that a massive transfusion, and you have to replace FFP, fresh frozen plasma, and platelets, or have to give fresh whole blood, which contains plasma and platelets in it. Now, it's important to recognize hemorrhagic hypovolemia, because often in children it's missed, and that is, children can become very hypovolemic. They can lose like 30% of their blood volume at least before they get hypotensive, and they do that, as we've talked about before, because they get tachycardia and vasoconstriction. They can compensate for hypovolemia much better than adults can, but they'll look pale and they'll be tachycardic, and they'll have cold peripheries, and they'll have a narrow pulse pressure, and they'll have vasoconstriction. So that's what they'll look like if they've got hemorrhagic hypovolemia. And so if you see a child like that who's bleeding, then they need to have blood. Then consider that you either give fresh whole blood if you can get it, or you have to replace fresh frozen plasma and platelets. Again, a different sort of transfusion for surgery, so post-op surgical bleeding or trauma. Okay. All right. Well, I was going to stop there, and that's all we're going to talk about today. So we've talked about two sorts of congenital anemia, G6PD deficiency, and we've talked about thalassemia, and we've talked about how to give a blood transfusion. And so I might stop there and see if there's any questions that you might have.